Bladder cancer is the 7th most common malignancy in men and the 17th most common in women. The incidence varies between different parts of the world, and it is more common in men than women, with a male-to-female ratio of 3:1. In most cases, the bladder cancer arises from the urothelial cells of the urothelium. The urothelium is the inner lining of the renal pelvis, the ureter, the urinary bladder, and the proximal parts of the urethra. In areas where the parasitic trematode schistosomasis is common, the patient may instead develop a squamous cell carcinoma of the bladder due to a chronic cystitis caused by the parasitic infection. The rest of this session will focus on the urothelial carcinomas of the bladder, since they account for more than 95% of the cases. The most well-known risk factor for developing a urothelial carcinoma is tobacco smoking, and the dominating symptom is macroscopic hematuria, although the patient may experience irritative symptoms from the bladder, such as frequency and urgency. Due to the high risk of an underlying malignancy in the urinary tract, it is mandatory that all patients with macroscopic hematuria is investigated, assessing both the upper and the lower parts of the urinary tract. This is best done by a computerized tomography and a cystoscopy of the bladder, as already mentioned in the previous section. Once a bladder tumor has been found, the patient will undergo surgery with a transurethral resection of the bladder tumor. The purpose with the transurethral resection is to remove the tumor entirely, if possible, and to get an adequate specimen for the pathology report. Bladder cancer can be divided into two main groups, namely the non-muscle invasive bladder cancer and the muscle invasive bladder cancer. The non-muscle invasive bladder cancers are confined to the urothelial layer or the submucosa of the bladder wall. This group can also be divided further into two groups. One is the tumors with a low risk of progression, and the other is a group of high-risk tumors with a high risk to progress into more advanced disease. For the non-muscle invasive bladder tumors with a low risk of progression, the treatment is a transurethral resection of the tumor. Some patients are also offered an immediate post-operative installation of a chemotherapeutical agent into the bladder to prevent recurrences. In this group, recurrences are very high, and the patients are therefore followed with cystoscopies on a regular basis. If the tumor reoccurs, this will also be resected transurethral. For the non-muscle invasive bladder cancers with a high risk to develop a more advanced disease, it is not sufficient with a transurethral resection only. These patients should be offered a series of intravesical installations with BCG. BCG is a shortening for Bacillus calmette-guerin, which is the vaccine that you give for tuberculosis. Low attenuated mycobacteria are installed into the bladder and cause a massive immunological response, attracting different types of white blood cells that will help to eliminate the bladder cancer cells. These patients are also followed closely with cystoscopies on a regular basis. Muscle invasive bladder cancer means that the tumor has invaded the muscular layer and gone deeper into the bladder wall. These patients cannot be cured with a transurethral resection. The cure for muscle invasive bladder cancer is a cystectomy, where you remove the entire bladder. In a few selected cases, the patients may be offered a full-dose radiotherapy against the bladder instead of a cystectomy. After having removed the bladder, the urine has to come out in another way. In the 1950s, the Bricker deviation was invented. You then take 20 centimeters of the distal ileum, that is the intestine, the small intestine, and you connect the ureters to one end of the ileum, and then you pull the ileum through the abdominal wall. The urine will then drip through this conduit and out on the outside of the abdominal wall. Therefore, the patient needs to have a collecting bag to collect the urine. A couple of decades later, they developed the Cox Reservoir. You then need to take a longer part of the intestine, about 50 to 60 centimeters. You cut it open and you fold it into a pouch. You connect the ureters to this pouch, and then you create a stoma from this pouch out on to the skin surface of the abdominal wall. The urine can then be stored in the reservoir and is emptied when the patient enters a catheter through the stoma in the abdominal wall into the reservoir. Yet sometime later, the Orthotopic Neo Bladder was developed. You then use 50 to 60 centimeters of the intestine, and you again create a pouch, but the pouch is now connected to the urethra. The patient can then void the normal way using abdominal pressure. For patients where the bladder tumor has grown through the entire bladder wall and spread to other organs, that is, metastatic disease, there is no cure. But the patient can receive chemotherapy to reduce symptoms and prolong survival. The lining of the bladder is the same as the lining of the ureter and the renal pelvis, that is, the urothelium. One can also get a urothelial tumor in the upper parts of the urinary tract. Sometimes it comes as a recurrence after a bladder cancer, but that is very rare. Sometimes the patient may also have a concurrent upper urinary tract urothelial cancer at the same time as the diagnosis of a bladder cancer, but that is extremely rare and occurs in less than 2% of the patients. The upper urinary tract urothelial carcinoma can also start in the upper urinary tract, that is, in the renal pelvis or in the ureter. The treatment for an upper urinary tract urothelial cancer is to remove the entire system on the affected side. That means to surgically remove the kidney, the ureter, and part of the bladder wall where the ureter enters the bladder. It is not uncommon that an upper urinary tract urothelial tumor can reoccur in the bladder. Therefore, these patients have to be followed with cystoscopies on a regular basis.